Good morning. It's Dr. Dale Bratzler, University Chief COVID Officer and Chief Quality Officer at OU Medicine. Really a pleasure to be here today. I'm going to give you a brief update of where we're at in Oklahoma with respect to the COVID pandemic, and then talk about a few of the new studies that were done this week that I think are important to know about. So as of yesterday, we had 55,500 new cases, that confirmed cases in the state of Oklahoma, 778 deaths. In the past week, we've seen just under 5,000 new cases, 4,800 in fact, and 69 deaths in the state. We continue to see fairly substantial numbers of deaths. Again, most of the deaths are in patients who are age 65 and older, though there are a few that do occur in patients below that age group. Right now, if you look at the rolling average of new cases in Oklahoma, we've actually seen a slight upward trend for the past 2 weeks. We're seeing on average about 700 new cases each day in Oklahoma. The other thing that I've been watching very closely is the percentage of tests that are being done that are positive. This week so far, through 4 days, 10.5% of the tests that have been run have been positive, which is an increase now for the past 2 weeks in the number of tests that are actually coming back positive. So again, to me, it highlights that we're continuing to see community spread of this particular virus. This week, we still have more than 500 people in the hospital. There were just over 400 people that were in hospitals with a confirmed case. In other words, their test was positive and they're in the hospital, and just under 50% of those patients are in the intensive care unit. So we very steadily have had more than 200 people a day that have been in the hospital in an intensive care unit. And I think because of that, when you see people who are that sick with COVID-19, we expect that we're going to continue to see some deaths in our state from COVID-19. I'm sending out a handout today that details all of the state numbers, but also wanted to highlight a couple of other studies that came out this week. One that was interesting that came out from the CDC was a very well done study looking at transmission on an air flight. The flight happened to be from Italy to South Korea, so it was a relatively long flight. But in that study, they were able to very effectively demonstrate, because of the controlled circumstances of that flight, that there was asymptomatic people on the flight who spread the virus to others who were on the flight. So we know that you can still see transmission of COVID-19, the virus, on airplanes. And they highlighted the things that I think all of you already know, that you need to wear your mask from the moment you get to the airport through check-in process in all the common areas on the flight and after the flight. Secondly, hand hygiene, because it is possible that contaminated surfaces on airplanes could be a source of infection, and that's still considered very important. And then whenever possible, particularly before you get on the flight, in the boarding process and others, maintain physical distancing to help protect yourself from others around you. I thought that was an interesting and well done study that came out of the Centers for Disease Control. The second thing that did come up this week was, as you know, the CDC very quietly changed their recommendation on testing of asymptomatic individuals for COVID-19. And in that particular recommendation, they basically said that if somebody's exposed to COVID-19 but they have no symptoms, that you don't have to do testing. The medical community, the public health community all came out very strongly against that position, and in comments that have come out yesterday, principally the director of the CDC, Dr. Robert Redfield, has walked those comments back a bit. The actual language on the CDC website has not changed, but they've walked that back, because those of us in public health feel that if we're going to contain COVID-19, one of the things that we have to do is identify people who are infected, isolate them to stop the spread of the virus to other people. And then finally, I wanted to highlight a study that came out of the UK, a large study, 651 children that were admitted to the hospital with COVID-19 at 138 hospitals. And actually, it was a very interesting study because, again, it showed that children who, even if they're sick enough to get into the hospital, don't have as severe disease, and the death rate was very, very low. Again, it wasn't zero, but it was quite low, and again, it confirms what we know, that the mortality in this disease, age is a real predictor of mortality from this disease. So there have been well-documented deaths of children in the United States from COVID-19, but it's rare, thank goodness. So I'm happy to take questions.
Okay. I just had a question from when you were talking about the air flight, the transmission on the flight. So you mentioned that you pointed out that that's a long flight. Would risk be less if I was just hopping on a commuter down to Dallas or something?
So the question is about, is there a difference in the risk of COVID-19 transmission on an airplane flight that's a short, maybe commuter flight versus one that's long distance? Remember that the definition of a direct contact is to be within 6 feet of somebody for 15 minutes. There are a few flights that are going to be less than 15 minutes. So I would say in general, yeah, the longer you're on a plane, particularly if you're in a setting where you're removing your mask to take a drink of water or anything else, or eating, that would increase your risk of infection. So longer flight probably has a greater risk, but what they showed in this study was that the transmission of the virus, because nobody that was symptomatic could get on this flight. It was a flight to get nationals from South Korea back to their home out of Italy. So they documented asymptomatic spread of the virus.
Kevin at Telemundo was asking if the Hispanic population is still being disproportionately affected by COVID-19.
Yeah, so the question is about the Hispanic Latino population and whether or not they're being disproportionately affected. The answer is yes. Even if you look at data in Oklahoma, the number of confirmed cases still has a higher proportion of Hispanics in the confirmed cases than we know the population of Oklahoma includes. So they are being increasingly at a disadvantage. The other thing we know is that many of the households, the Hispanic households, may be multi-generational, and that increases the likelihood that some older person living in the household may get infected, and of course they don't do as well when they do get infected.
Jackie at Fox 23 in Tulsa, the State Department of Health announced that they will now change their COVID alert map to reflect local hospital data, something that you had advocated for after the map was created. What do you think of those changes, and how can those changes better reflect the coronavirus situation county by county?
Yeah, so the state map for risk that was done by county, the color-coded map, I didn't think was terribly useful because it looked at statewide hospitalization rates and statewide hospital capacity. So you could have, let's say, the Tulsa metropolitan area that could have no hospital beds available, but because there were beds in other parts of the state, Tulsa County wouldn't end up in the red zone, which didn't seem appropriate. We're not going to transport patients across the state, particularly going from a large academic center to a smaller hospital with COVID-19. So I've not seen the reiteration of the map since they changed the methodology, but I am happy that they're reevaluating that because I think it makes much more sense to look at local hospital capacity when you're thinking about what the risk is in any particular county.
Okay. And just stressing, you discussed this in your introduction, but deaths continuing to spike. Is this still mostly related to the high number of people we have in the ICU? And what are we seeing in terms of the testing and positivity numbers?
Yeah, so I think that the reason we continue to see a substantial number of deaths in Oklahoma is because of the fact that we have older people that are having confirmed diagnoses, people that get hospitalized, and we have more than 200 people a day in the intensive care unit in Oklahoma hospitals right now. If you look at some of the older published literature, and when I say older, I mean from a few months ago, the hospital mortality rate of an ICU patient with COVID-19 ranged from 20 to 30%. I think it's better now because of better treatment. However, a proportion of patients who are that sick with COVID-19 that end up in the ICU are likely going to die, and I think as long as we have continued high rates of hospitalization and a large number of people in intensive care unit beds, we'll continue to see some deaths. We also know we've seen some outbreaks in nursing homes again in Oklahoma, and some patients may have elected not to go into the hospital, and they may be receiving things like hospice care. So again, not all of the patients who die from this disease die in the hospital, but I think we're going to continue to see deaths for a while because we have a lot of sick people with COVID-19.
Angela at K4, can you address the new CDC recommendation that, and I think you did already, recommendation that asymptomatic people don't need to be tested? I think you talked about that at the beginning.
Yeah, I did. So the CDC recommendation, again, Robert Redfield, the director of the CDC, actually in public comments that came out yesterday, has noted that he backed off on those, walked backwards from those comments, but it's still on the CDC website. But I think, honestly, many states, most public health professionals are not following that new advice and still recommending that if you're a direct contact, that you should be isolated and potentially tested.
What are your thoughts on the emergency approval for plasma treatment?
Yeah, so this week, a number of us were surprised when the FDA granted emergency use authorization for convalescent plasma, which is the plasma from somebody who has recovered from COVID-19, to hopefully give the plasma to a person with COVID-19 to get their antibodies in that patient to help them fight off COVID-19. We were a bit surprised because just a couple of days before that FDA announcement, the Infectious Diseases Society of America, which is the largest organization of infectious disease specialists, in their guidelines had recommended that convalescent plasma be used, but only in the context of a clinical trial. Just recognize that there still is not definitive evidence that convalescent plasma will help all patients and which patients it will help. So the concern with the FDA emergency use authorization is that people will get it, they'll get it routinely outside of clinical trials, and we may not learn which patients would really benefit from receiving it and what the actual benefit is.
She also asked, the FDA gave emergency approval for a 15-minute COVID test. How accurate would that be?
Yeah, so Abbott, a company, has come out with a new credit card-sized test that you can do for COVID-19. It's an antigen test. And essentially the way it works is you have to go see a medical professional so they can monitor the collection of the nasal swab. You rub it on the card, wait 15 minutes, and it gives you the results. It's not going to be as sensitive as going to a regular laboratory and getting a PCR test as an example. So it's not going to be, but the reason many of us in public health have been looking for a low-cost testing option is that so that we can test lots of people. So you could potentially, I would love to see Abbott get this to the point where it was over the counter, where a YouTube video showed you how to use the test and do the test, so that you could do simple testing rapidly but often. So it's not as sensitive. So if you're infected, it might come back negative. It may not be as good, but you just repeat it daily or every other day until your symptoms are gone. And if you're really sick with this virus, it likely will be positive at some point during the illness.
Interesting. Chuck at K4 is asking if you just comment what your thoughts are about the large crowds of college students in bars around Campus Corner and in Stillwater.
Yeah, it's one of the things that we've tried to communicate to the students, certainly on the Norman campus and through the University of Oklahoma, that personal responsibility is part of controlling the spread of this particular disease. And I think, the football team was a great example where we saw it, where we had very, very few cases in our football team. And then they were given a week off, and we saw them come back and have a number of positive tests. As we've discussed at our university a lot, we're depending on the personal responsibility of 18 to 22-year-olds to make the decisions that will keep them safe and not risk other people. So again, it's part of the reason the White House task force explicitly recommended that bars in Oklahoma be closed, because we're still a red zone state under the White House criteria.
you ever support using the rapid antigen testing for the virus on the campuses?
So yes, so particularly the test that was announced this week, if we had a test that we could deploy across, on the Norman campus as an example, we have 25,000 students that are matriculating there. To do the current testing that requires that you go to a lab or get the nasopharyngeal swab it's daunting just to try to do that many people, plus it's incredibly expensive. But if you had a rapid antigen test that was quite inexpensive, that you got the results back very, very quickly, then you could deploy it to a much larger proportion of the student body routinely, and perhaps then stem the spread of the disease by identifying those people who are positive much earlier.
So would those numbers be reported if we use something like that? Or?
Well, so right now in the state of Oklahoma, a rapid antigen test, which is what is often done at most urgent care centers, they are using a machine-based rapid antigen test. Those tests are reported to the health department. A positive test, as we've discussed before, is very good, and there's just almost nothing else that'll make it positive other than COVID-19 infection. But currently they're listed as probable cases. So if you go to the CDC's website and you just say, I want to know about COVID counts, you can hover over the state of Oklahoma. You'll see our confirmed cases, but then you'll also see the number of probable cases we have in the state, and those get counted by the CDC as probable cases. Currently in Oklahoma, if you go to an urgent care center, have a positive antigen test, you probably have COVID-19. In fact, you do have COVID-19 until otherwise proven, but those do not get counted in the case count for the state, that daily update that we get.
Corey at the Tulsa World, what are your overall thoughts on the White House Coronavirus Task Force reports? And specifically as it relates to limits on gatherings, bar closures, and restrictions on indoor gatherings in yellow and red counties.
So the White House Task Force basically has criteria that if your state has more than 100 newly confirmed cases per 100,000 population per week, which we do, you're in the red zone. And they look at that data. You can drill that data down at the county level. And in fact, there are many online maps that already show you what counties in Oklahoma have a higher than expected proportion of cases per 100,000 population. The White House Task Force recommendations are the same ones that many of us have been making for a long time. We should have a mask policy statewide. Again, I think we just keep dragging this out by not getting to universal mask policy. Recommended closing bars. They recommended that you shut down eat-in dining at restaurants. Again, restaurants can stay open and do carry-out and other things, but they recommended that you do shut down your indoor dining. Gyms are another hot spot for many, many places. We're going to keep, and then they recommended also limitations on the size of gatherings. We're going to keep seeing cases in Oklahoma until we start taking and doing some of these public health interventions that have been shown to reduce spread of the virus. Again, I think we saw it work really effectively in Oklahoma early in the pandemic, and then as we backed off, we saw big case counts happen in multiple states, but also Oklahoma. And now we're stuck at around 700 new cases a day. We're nowhere close to those low levels that we'd achieved earlier when we really clamped down.
Okay, Phil at Fox is asking, testing statewide has declined 46% since peaking in late July. Any idea why?
Yeah, it's a great question. The question is, why has the testing gone down in the state of Oklahoma? And it's really not clear to me. I don't know whether some of it's COVID fatigue. I think a lot more people are going to urgent care centers, and some of those tests may or may not show up in the actual data. They don't show up in the PCR test that the health department reports routinely. So I do think that some of the testing that is occurring isn't being counted. But it is a perplexing question because we still have fairly substantial community spread of this disease. There's actually unused testing capacity in Oklahoma right now. We have more tests available than we have people requesting tests. And so again, we encourage people, if you have concerns, if you've been around somebody with COVID-19, if you have symptoms and you don't know, call 211, find one of the local places that are doing testing and seek out a test.
Kevin at Telemundo wanted to follow up on his question earlier. Said various studies prove that a large percentage of Oklahoma's Hispanic Latino population do not have health insurance, which can pose an obstacle when fighting this virus. Many of these families depend on home remedies such as teas to fight any infection. What are the best ways to treat this virus at home?
So the good news is that most people who get infected with the SARS-CoV-2 virus that causes COVID-19 don't require hospitalization, do survive. So that's the good news. And honestly, just symptomatic treatment at home. So if you have a fever, use drugs like ibuprofen or acetaminophen, and just the same things that you would do for a case of the flu. Most patients can stay home unless their oxygen level starts to get low. When we see people with low oxygen level, those are the people who are most likely to end up in the hospital. There is no proven medication, treatment, vitamin, supplement, or anything else that either prevents COVID-19 or will treat it. There is none that's been proven. So again, it's symptomatic. If you did test positive, but you're not sick enough to be in the hospital, we recommend that people go home. We recommend that they isolate from their family, so sleep in a separate bedroom, preferably use a separate bathroom, and avoid that. I think one of the points the questioner made that's really important, though, is we know that sociodemographics do play a role in the outcomes from this disease, and people of lower socioeconomic status are more likely to be infected, and they don't do as well when they get the infection.
So he followed up by, there's a negative stigma surrounding the Hispanic population in hospitals. Many of them do not go to a hospital when they are incredibly sick due to lack of insurance or trust for medical officials. What would you say to these families?
I hope anybody that is really sick with this illness will seek medical care. All hospitals in this state have an obligation to provide care to patients, whether they have insurance or not. It's part of the laws of our country that if you're really sick, please go to the hospital. If you're having trouble breathing in particular would be a common reason to go to the hospital. If you're coughing and you can't control it, please go to the hospital and seek care, because the good news is treatment for this disease has gotten much better. We know what to do now. And when people come into the hospital with bad pneumonia or difficulty breathing, there are all sorts of techniques that our physicians are using to improve their outcome. There are medications that we're using now that may improve outcomes. They need to be administered in the hospital setting, and please encourage people to come into the hospital. There should be no stigma. Think about it. There are more than 550,000 people in Oklahoma who've been infected with this virus. It affects all generations. It affects all income levels. It affects all races, ethnicities. There should be no stigma.
That's all the questions that we have today. Anything you want to wrap with, or?
No, I think those are the key points.